Ear anthropometry. A thorough understanding of the sizes and proportions of the normal, external ear is critical for plastic surgeons, reconstructive surgeries of the ear, and for facial rejuvenation. Different methods for measuring the ear proportions and angles. Guidelines for taking standard ear measurements. The patient should sit upright with his head in Frankfurt horizontal plane, i.e. orbitally and trajan to be in the same plane. Orbitally is the lowest point on the lower margin of orbit and trajan is the point on upper margin of tragus. Landmarks on auricle and face to be identified once the head is in Frankfurt horizontal plane and marked on the skin. Standard anthropometric instrument with optimal precision to be used for taking measurements. To assess auricular protrusion, measurements are made at 1. The superior-most aspect, the helical rim. 2. The lateral-most projecting point along the mid-rim. 3. A point level with the intertragal incisura. The ideal auriculocephalic distances are 10 to 12 mm superiorly, 16 to 18 mm at the middle third, and 18 to 20 mm inferiorly. Average ear measurements include about 15 mm from the temporal skin to the lateral skin surface of the superior pinna. The normal ear sits about depth of a sideways adult little finger width. The lower portion of the pinna sits about 20 mm from the mastoid skin to the lateral skin surface. Ear measurements. 1. Auricle length, AL, the distance between the most superior point of the auricle and the most inferior point of the earlobe on lines parallel to the base of the auricle. 2. Distance from the highest point of the auricle to the bottom of the intertragic notch, TIN. 3. Auricle width, AW, the distance between the most anterior and the most posterior points of the auricle. 4. Distance from the tragus to helix, TH. 5. Distance from the tragus to antihelix, TAH. 6. Earlobe width, EW, the distance between the most anterior and most posterior points of the earlobe. 7. Earlobe length, EL, the distance between the most inferior point of the earlobe and the deepest point of the intertragic notch. Normal ear is oriented approximately 20 degrees posterior from the vertical axis. The length of the adult ear is approximately 55 to 60 mm, the width approximately 55% of the length. In a clinically normal ear, the helix should project 2 to 5 mm more laterally than the antihelix on frontal view. When the ear is viewed from above, the angulations are a result of a 90 degrees conchomastoid angle and a 90 degrees conchocephalic angle. With protruding ear deformities, the conchomastoid angle may remain at 90 degrees and the conchocephalic angle will become obtuse, between 140 degrees and 150 degrees. To access the degree of protrusion, the auriculocephalic angle and the scaphoconchal angle should be determined. A normal auriculocephalic angle is roughly 25 to 35 degrees. An abnormal or protrusive angle is generally greater than 45 degrees. The scaphoconchal angle is normally 75 to 100 degrees. A lack of an antihelical fold, which causes failure of the ear to fold normally, will typically present with a scaphoconchal angle of greater than 100 degrees. Proportions of the aesthetic ear. The long axis of the ear inclines posteriorly at approximately a 20-degree angle from the vertical, green angle. The ear axis does not normally parallel the bridge of the nose. The angle differential is approximately 15 degrees anteriorly to the axis of the dorsum of the nose. Horizontal tangential lines drawn through the superiormost tip of the ear should pass through the level of the supraorbital ridge when the head is placed in the Frankfurt horizontal plane. A line drawn through the inferiormost pinna lobule should align with the base of the nasal columella. The ear is positioned at approximately 1 ear length, 5.5 to 7 cm, posterior to the lateral orbital rim between horizontal planes that intersect the eyebrow and columella. The width is approximately 50 to 60% of the length, width, 3 to 4.5 cm, length, 5.5 to 7 cm. The anterolateral aspect of the helix protrudes at a 21 to 30 degree angle from the scalp. The anterolateral aspect of the helix measures approximately 1.5 to 2 cm from the scalp, although there is a large amount of racial and gender variation. The lobule and antihelical fold lie in a parallel plane at an acute angle to the mastoid process. The helix should project 2 to 5 mm more laterally than the antihelix on frontal view. To complete descriptions of the proportion of aesthetic ear, we have to discuss complex angles of where the various components of the ear are in relation to other structures. These include the conchomastoid angle, conchocephalic angle, and auriculocephalic angle. Although these angles are important for understanding the normal and abnormal ear posture, they are rarely used in treatment planning. The normal posterior wall of the conchal bowl is set at an angle of approximately 90 degrees to the mastoid. A second 90 degrees angle is formed at the antihelical fold and is called the scaphoconchal angle. These two angles, in combination with the curvature of the helix, set the auricle adjacent to the scalp at approximately 25 to 35 degrees, forming the auriculocephalic angle. Notes. Orden shows a three-tier concept of associated parts of the helix with each tier abutting the other at a 90 degrees angle. Thus, the conchal floor meets with the conchal wall at 90 degrees. The conchal wall meets with the scapha antihelix complex at 90 degrees, and finally, the scapha antihelix complex adjoins the helix at a 90 degrees. Lobular size and position should be aesthetically pleasing relative to the rest of the ear, being neither prominent in overall size and thickness, nor laterally oriented. The ear should be carefully observed from the anterior, lateral, and posterior views to evaluate deformities and relative relationships. The deformities most commonly addressed by otoplasty are as follows. 1. Absence of a proper antihelical fold. 2. Conchal excess. 3. Prominent helical tail. 4. Prominent lobule. 5. Helical rim deformities. Conchal show. How do we measure the conchus? What is the average conchal show? In some author opinions, the absolute conchal depth has no significant importance. It is only the conchal show which is important from the aesthetic point of view. It is very useful to know the conchal show. It helps the surgeon decide whether or not to do a conchal reduction and reduces subjective errors in prominent ear correction. Conchal show is defined as the distance in millimeters between a point where an anteroposterior line, drawn from the cheek, meets the conchal wall, and a point on the antihelical fold. Between 8 and 11 millimeters, the conchal show is considered to be good. The mean conchal show is 10 millimeters. A. The 8 to 10 millimeters marking is made on the posterior conchal wall, and the remainder of the conchal bowl is traced for excision. The tracing includes the entire conchal sewer and nears the external auditory canal. B. A sharp arrowhead is made at the helical radix. All cartilage within the dotted lines will be excised from the other side of the ear. The concus affects the prominence of the ear threefold ways. The overall enlargement of the concus projects the ear away from the mastoid surface. An extension of the helical crus across the concus creates a firm cartilage bar that pushes the ear outwards. The effect of the angulation of the cartilage, at the junction between the cavum concus, and the sweep of cartilage up to the antitragal prominence, affects the position and prominence of the lobule, earlobe, and lower third of the ear.